People are living longer and often better, thanks in part to medicine and pharmaceutical treatments for conditions that might have once been crippling. That can also result, however, in people taking many different meds all at once. And that's where problems can crop up. With us now to explain, in the nation's capital, Dr. Rohit Gandhi. He's an emergency physician and clinician researcher at Montfort Hospital, right near downtown Ottawa. And not only is he appearing on this program for the first time, this is his first time on television ever. So, Dr. Gandhi, it's great to have you here. How are you doing?
Thank you so much. Thanks for the warm welcome. I'm doing well. How are you?
I'm terrific, thank you. And we'll make this as pleasant an experience as possible, okay?
Thank you.
Let's start with this, polypharmacy. How would you define it?
So I think polypharmacy is very classically described as an individual who's on 5 or more medications on a daily basis. But that thinking has shifted a little bit to be less about the number of medications and a bit more about whether the medications you take are actually causing you more harm than benefit.
Sure. And how prevalent would you say that phenomenon is?
Well, I think it's something that affects Canadians greatly and a lot of other wealthy nations as well. About our citizens aged 65 and older are on an average of 7 different classes of medication, which is actually quite substantial. And that becomes an issue in terms of polypharmacy, as we know that each additional drug that we take as an individual increases our risks for adverse events. So this problem, I think, as we grow the number of medications available to us in terms of pharmaceutical options, becomes quite an issue here in Canada.
Let's just sort of figure out how this happens. I guess obviously at some point you're on one drug, and then another, and another, and another, and suddenly you're on 5 or 6. I mean, how does that happen?
Yeah, well, really, there's a lot of different reasons, and I think a lot of different players involved in creating that problem of polypharmacy. A lot of care can be fractionated at times. Patients don't have a primary care physician, so they're seeking care from other providers. And when you have that type of medicine that's being employed, you end up on more medications than you might be beneficial for you. Even patients who do have a family physician but have specialists involved in their care who are focused on one system or one chronic disease end up becoming victims of polypharmacy because of all of the players involved, which at times can be beneficial. But as we age and as we continue to add medications and re-prescribe them without that thoughtful act of de-prescribing, we end up with a lot of medications on board.
Well, I get what you're saying, but if each medication that a person is taking is designed to tackle some difficulty that the patient is having, and they all work reasonably well together, what's the problem?
Well, that's the real question. Do they work reasonably well together? A lot of studies that are done on medications and their use for treating a disease are very tailored to that specific disease and that medication in that setting. We don't often study how medications interact with each other. And I think that's one of the sources of the problem. The other part to that is when we start a medication for a certain condition or there's a benefit at the time, that doesn't necessarily mean it holds throughout your life. As I mentioned, you may start something for, let's say, your high blood pressure, and it may be helpful to have targeted, aggressive control of blood pressure at a certain age in your life. But as we age and our physiology changes, we add more medications, as we alluded to earlier, the effectiveness of that medication might not be the same. The need to treat aggressively might not be the same. And we end up with potentially a medication that was helping us at one point, but maybe now is causing us more harm.
All right, you're an ER doc, right?
Correct.
Okay, so tell us how this sort of plays out in your personal experience when you're working in the emergency room.
Sure. Well, I mean, it's not uncommon for us to see a patient in an acute setting, grab their files, and go through a list of medications that's 10 pages long. Or we have a patient that sort of comes in with their Ziploc bag, complete with pills, old, new, expired. And so that's like a very, very visual part of polypharmacy. But of the patients we end up admitting to hospital, the ones that just can't go home, about half of them are on at least 10 medications. And we know that increases your risk of having an adverse drug event, so a side effect of your medications. And it's quite surprising. I think being on 10 drugs increases your risk about 5 times of being admitted for an adverse drug event. So in my daily practice, I'm seeing a lot of polypharmacy, a lot of medications that are unnecessary and are probably leading in an unrecognized way to admissions to hospital due to these side effects.
Dr. Gandhi, let me just make sure I got this right. 10 medications every day?
Every day.
Multiple times a day?
Yeah, this is a problem that is not just about taking 10 medications a day and all the polypharmacy. It's, as you mentioned, just understanding how to take them, when to take them, complying with them. People even get full from having 10 medications for breakfast. So it is 10 per day.
You might have a patient, for example, who's taking 40 different tablets a day for a variety of different things.
Yes, exactly. It's not just the number, it's the number of tablets as well, right? So that's quite right, Steve.
That's astonishing. How often do you find a situation where somebody comes in and, I don't know, let's say they got a parent in their 80s, and so they're in their, whatever, 40s, 50s, 60s, and you, the doctor, says to the child of the person who needs treatment, okay, what's your mom or dad on? And they give you this quizzical look like, I don't know. How often does that happen?
Yeah, I mean, that is a problem, I think, that we see all the time. Even people on 3 or 4 medications, my parents as well, I ask them what they're on, and it's difficult. And I think it becomes difficult for clinicians as well, because right now in Canada, we don't really have a great repository to understand what medications our patients are really on and where they come from. And so when we speak to their loved ones who are trying to reconcile that for them, it's overwhelming. And we really appreciate some of those families who actually have a list in front of them. And so in the rare cases, we really do get a nice list, and some people are very much involved. But, you know, it's hard to blame the family because it's a very difficult task to not have a medical background and manage so many medications for a loved one.
Sure, but I mean, as long as we're on the topic, anybody watching this, find out what your folks are on and make a list, right? I mean, that's just common sense, so that if they get into trouble, you can give the doctor good advice and good information.
Yeah, I think that's a great piece of advice, Steve. It's very under-recognized how important it is to have a good medical record of medications coming into hospital.
All right, then. So we've got this circumstance here where some people are on a great number of medications numerous times a day, and let's figure out, if this does become a problem, what guys like you intend to do about it. There's a term called de-prescribing. What is that?
So de-prescribing is a fancy term to have what we call a prescription checkup, to remove medications that are unnecessary, that aren't providing any benefit, and are potentially compounding and providing harm. So it's really the active act before we get to the hospital or ICU, where we're trying our best to remove medications that are unnecessary and simplify things for our patients while keeping the quality of their care at a very high standard.
How do you know if the drugs are unnecessary?
It's a great question, and it's probably a very complex answer because everyone's very different. And drugs, like I mentioned, are beneficial at one time in your life, but later in life, they may not be so. And the interactions aren't always studied. Now, to really understand, if a drug is unnecessary, there's a lot of criteria that are starting to creep up now. And we've had lists for years, some of them like the Beers criteria, a physician made, that sort of indicates we prescribe these drugs out of habit a lot of the time, but the indication isn't always there. We talk a lot about the number of patients we need to treat. It's called the number needed to treat, which sort of shows how many patients do we need to give this particular drug to before we see one person having a benefit, which is really interesting. But on the flip side, there's also the number needed to harm. And that means how many times do we give this medication before one person has a bad event or an adverse outcome? And really weighing these two things is the first step in helping understand whether or not this drug is actually doing us any harm and whether or not the benefit is outweighing that.
Well, let's figure out how to get out of this pickle then. No doubt it's happening, this overprescribing, because doctors do it, or patients demand it, or pharmacists go along with it. So of those three, who's most responsible for sort of turning this vehicle around?
Yeah, well, I would have to argue that all three of these parties and probably other healthcare practitioners are involved in this problem. And I think the solution, if it doesn't come from all three parties, I think that that's going to be the only real way that we're going to get a real good headway on reducing polypharmacy. I think from the patient perspective, it's very important to be an advocate for your own health. And I always physicians are stretched thin. There's lots of competing interests. And as a patient, I think it's important that we take our healthcare, we understand our healthcare, and we do things like you suggested, making a list of medications, having that available. But really to start the conversation with your family physician, to go in and ask maybe for an appointment just about de-prescribing. I think having that as a first step will go a long way. But certainly the family physician has a role. They have a role in preventing these adverse events and going through medications to actually help our patients understand with time if they still need to be on them. And I think that's a visit that's very much worth having. And on the other realm of pharmaceutical, we get a lot of information from pharmaceutical companies on how to start drugs and how to give them and when to give them. But we don't have a lot of information from them on when to stop them or how to stop them. And I think the onus there also lies with that type of industry to help our physicians and our patients de-prescribe.
Now, that's a great point. So you think that there's the possibility that doctors don't realize they're overprescribing simply because they put a patient on the meds, but then they don't ever tell the patient, oh, incidentally, you don't necessarily have to take this for the rest of your life. That's an issue, eh?
It is an issue. And I think at times, prescriptions expire, right? So you go back and you renew your prescription every 3 months or 6 months. And I think that's an important task. And it's sort of become something that we do routinely. But I think what we need to do, as you sort of alluded to, was to really, after a certain number of years, have check-ins or reminders that we really need to revisit whether this medication is worth it. And I think patients need to sort of ask their physicians, how long do I need to be on this for? And can we talk about this in 2 years or 3 years, or whatever interval is necessary for that particular disease process and medication?
In which case, let's finish up on this. Patients get meds from a variety of different places. You can get meds at a walk-in clinic. You can get them from your GP. You can get them from a specialist. So again, all these players have a role to play, presumably, in this drama that you're describing for us. Do you see a quick and dirty solution to turning this thing around?
Well, I wish I did. And to compound the problem, there's also over-the-counter medications. So it's not just from prescribers. It's patients themselves that may take an over-the-counter medication that maybe has little harm, but compounded with your 10 medications can do a lot. So in terms of a quick and easy solution, there probably isn't one. I think we need to first have a system in place where we can access patient medication information in a very uniform way. So all providers can see that and access that, which doesn't exist today. But I think, putting on the radar prescribing and overuse of medications on patients and physicians' radar is important, and having the tools to educate them to de-prescribe, which we know is a time-sensitive, time-consuming, and complex process, would really help. A lot of my particular research that I do in the hospital has to do with providing physicians with individualized data on their performance, and actually allowing physicians to use data compared against their peers who practice in the very same setting as them to really understand, through audit and feedback, how much, let's say, each of their prescriptions on average are per patient they have, and providing that information in conjunction with education is probably where I think we're going to see the mark move a little bit, because we know that education alone and information alone doesn't really change behavior in a lot of different studies and cases in medicine. And we need to complement that with other things like audit and feedback and understanding really the motivation on why you need to change, and we need to help our patients to do so.
Well, having said that, let's hope we've done a little piece of that educational part of this puzzle here tonight on TVO. Dr. Rohit Gandhi from the Montfort Hospital in Ottawa, I want to not only thank you for being with us on TVO tonight, but I also want to tell you, you were excellent. First time on television, and you were terrific. So thank you, and I look forward to speaking to you again about whatever you're interested in as it relates to our healthcare system.
Of course. Thanks a lot for having me, Steve. I appreciate it.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.